Track 6, and we're back with the dog, Dr. Rand. How are you, my friend?
I'm doing better. How are you doing?
I'm great. I'm great. The show is picking up steam, and I'm glad to say that this week we actually have a question all the way from Dubai from some guy who actually trains with Big Ramy.
Right.
Unbelievable. So, yeah, it's you're getting around all over the world, Dr. Rand. People love you.
Yeah.
That's awesome. So, Dr. Rand, let's start right away with question number one. I have heard that growth hormone has less side effect than testosterone when used for a long period of time. Is this true?
Loaded question, because as with everything, dose is very important. And of course, are you using it for replacement purposes, or are you going super physiological, meaning more than you need? In general, riskiness with testosterone replacement therapy, you're going to be risking. Well, you shouldn't be risking shutting off your own natural supply. Obviously, we're also addressing an audience here that might be using testosterone beyond physiologic limits. So the risk would be you'd be shutting down your own natural supply prematurely, meaning it might not ever come back, although I haven't ever seen that. It's just a matter of patience, in terms of the length you're willing to go to wait for your testicles to come back online, assuming you're young enough. With an older person, again, it doesn't matter. As I joke, don't shoot the messenger, but what testicular function are we preserving by cycling replacement therapy? You came in here because you're below normal to begin with, so
Right.
okay, who cares if you shut it down? And the side effects, we all know about the side effects of testosterone. The things that can go wrong with growth hormone are obviously not long bone growth, but flat bone growth, the kind of stuff that gives you the Cro-Magnon look and the split in the teeth and all that good stuff from excessive use of growth hormone. Enlarged organs, that's not a myth. One of the reasons they use growth hormone for replacement purposes, if someone's deficient, is to counter the shrinking of the organs and function that occurs with age to some degree. So again, if you overdo it, if we're talking about supraphysiologic dosing of growth hormone, then you can run across the flat bone lengthening, which we don't want, and the enlargement of the organs. Anything else? Well,
What would that be? When you say that some overdosage of growth hormone, what do you consider an optimal or perfect dose for growth hormone on a daily?
Well, what's interesting with that is, paradoxically, the older we get, the less replacement we need to get us back up to quote-unquote norm. And that's not just because of course, the reference interval is lower, which, by the way, makes it even harder to pass muster with the FDA rules about prescribing it, because normal when you're older is much lower, so you have to be really, really low, obviously, aside from about 7 conditions for which they say it's fine to prescribe it. So adult growth hormone deficiency is very rare because of the way they set the standard. But at any rate, to get a youthful level, you need less replacement as an older person than you would as a younger person. But in general, side effects are limited at 2 IUs or below, and that should keep you in a physiologic range. We use IGF-1 as a surrogate marker for your growth hormone levels. It's just much easier to do that way because of the short half-life of growth hormone. And that'll probably put you somewhere, depending on your age again, but if it's appropriate use, it'll put you somewhere around maybe 275 for IGF-1. You're looking at about that range. If you're a little younger, maybe, I'd say 2 IUs is going to put you right in there. It'll keep you at the high end of normal.
So you don't need 4 IUs and 6 IUs, and some people do 18 IUs a day. That's way overdoing it.
Well, those are what I call bodybuilding dosages, and those are definitely super physiologic, and you can have side effects from that. And yet you look around the gym and you go, well, look at all these bodybuilders that are using crazy dosages, and again, a lot of it. Well, we just mentioned the high dose, but chronicity is an issue too. Are they using it for 10 years, or are they using it for
3 months,
a show preparation or something like that? And again, despite what you may read, we haven't seen the reefer madness type dangers that are supposedly attached to that kind of usage. Although again, we still don't know. So you have to just look around and see what we have. We've seen some pretty gross examples of what we refer to as GH belly.
Mm-hmm.
Probably incorrectly so. It's probably closer to IGF-1 belly.
Mm.
And I don't mean that because they're actually using IGF-1. I mean because GH is turning into IGF-1. And we don't know the exact mechanism. I challenge anyone to look online and do the research and find the mechanism. But you find a lot of that more now than before, I believe, because of dosages. And people are now, and this is another topic, using insulin
Yes.
with their growth hormone.
Yes.
And honestly, if you do conjecture over a mechanism, most likely would be the release of somatostatin as a response to the excessive dose of growth hormone, slowing the motility of the bowel. So think of it as just being backed up, severely backed up when you start. I mean, part of the mechanism when you start getting the belly as well as edema.
I see.
You're getting swelling. There's a lot of water in there too.
Yeah.
Because we call it GH belly or gorilla belly
Mm-hmm.
because it's you're diced and you're ripped, but your belly's sticking out the
Yeah.
Again, just conjecture at this point because we don't have any studies on this sort of thing. But
We certainly see it. But would you so to answer the question of people that are using from 2 IUs to 4 IUs to 6 IUs to 16 IUs, it's not going to work any better to use 16 than it does 4.
depends on what you mean by work.
I mean that's in bodybuilding terms.
In bodybuilding terms, yeah, I wouldn't say it's linear. The more you use, at least observing, and that's all I can do is observe and assume that what people are doing, they're being honest with me about.
Mm-hmm.
But what I've seen is around 5 or 6 IUs. Anything above that, I don't see much difference. I think you've got sort of an S curve.
Okay.
You're getting limited benefit after that level.
Okay.
And that's been backed up by a lot of guys that have been in the sport for a long time. Again, just doing the same thing I am, which is just observing these guys that are doing it.
Yeah.
They've done studies. Now they're with HIV positive patients where they've used as much as 6 IUs, usually lower like 5 IUs, for up to 6 months with no side effects.
Mm.
And simply a loss of visceral adipose tissue or the intra-abdominal fat.
Mm-hmm.
But you got to look at that and go, well, that's a unique population.
Yeah.
Possibly, certainly a unique population. Does it affect? I mean, can you make the crossover to a non-HIV infected population? Figure you're safe. We don't know.
Yeah, it's not. There's not that many studies then on.
No, because this isn't something. I mean, supraphysiologic dosages we don't look at that often unless we're treating a disease. Bodybuilders are using it for cosmetic reasons.
Yeah.
And so when you say, does it work? It works fine at a replacement dose to replace growth hormone deficiency at just 2 IUs. Or to treat, again, another exception is with HIV positive patients. The government subsidizes oftentimes growth hormone use for wasting syndromes like that.
Yeah.
And they're being recommended 18 IUs a day sometimes.
Yeah.
Which I think is
a lot.
It's crazy high.
Yeah.
But again, you get up into the higher dosages for cosmetic reasons. Certainly, it's going to work better than the lower dosages to a certain point, as we just discussed.
Okay.
And that brings up another point. I get asked a lot about some of the analogs which are legal. Sermorelin, which was originally formulated under the brand Jaref by a fellow named Richard Walker, who's a PhD who's now living in Tampa. The problem, that was the original analog. It's the analog of growth hormone releasing hormone, the first 29 amino acids, and it works similarly. And it was invented to treat dwarfism, but of course there are different types of dwarfism, and so it didn't work all the time, and we scrapped it. And we said, okay, well, we got to come up with something better that works all the time, and we came up with growth hormone, exogenous use directly, and back then, of course, we got it from cadavers. But Sermorelin certainly doesn't work as well for cosmetic purposes as does exogenous growth hormone, because exogenous, you can override the system, and of course you can leverage it and push it and get the results that much more quickly and demonstratively. But Sermorelin is a way better long-term play, or any sort of growth hormone releasing analog that we've got so far. I know there's a lot of peptides out there that are for research purposes only. In other words, they're not legal, they haven't been approved yet by the FDA. But Sermorelin is a long-term better choice. Why? Because you don't run the risks of any of the side effects that you might get from long-term excessive use of exogenous growth hormone.
Oh, wow.
Because you're telling the pituitary to produce its own growth hormone, okay? And in doing so, the whole thing becomes part of the negative feedback loop. So, for our intensive discussion, you can give yourself 10 times the normal dose of Sermorelin, and the body gives it the,
it's not
talk to the
overdose.
hand, man.
Yeah,
I've got enough here.
Yeah.
Again, you can push it a little bit above into supraphysiologic levels, but it's very, very safe to push it up to the maximum allowable by your body, and then you don't run the risk of overdoing it.
Wow.
It's also good, by the way, for, we mentioned the HIV positive population, something called lipodystrophy. And now they have something called tesamorelin, which goes under the brand name Agrifta, which I have to say works, and it's FDA approved, works better than Sermorelin in my clinical experience at releasing growth hormone and redistributing the fat that's associated. It's called lipodystrophy, associated with use of some of the drugs that we use to treat HIV positive patients.
Wow. That was a great talk. All right. Bodybuilders are watching this show. We have to talk about that.
I understand.
All right, thanks.
Okay. So when talking to a teenager, a male who's just getting started and wants to start using anabolic steroids, what are the side effects that he could be expecting? I don't want to scare him, just kind of give him the right information.
A teenager starting.
Did he say teenager?
Steroids.
Oh yeah, teenager. That shouldn't tell him anything then.
Well, I don't know how I can say without scaring him because, well, it depends on what scares you, I guess. The problem with using steroids or testosterone before you are actually deficient in it is something we alluded to earlier. Mm-hmm. You're going to be stopping your own production, endogenous production. And why would you want to do that, obviously? Well, I just want to get bigger for now. I understand all the reasons, so I didn't mean that to be anything but a rhetorical question, but you definitely need to consider that, again, with chronicity of use, you may never get your testicular function back to its original, meaning what it would have been at age 20 had you reached 20 without using anabolic steroids. So that's a big factor, and that's why I think rightfully so, we make it a point to scare teenagers away from this sort of thing, making it abandoned competition for amateur athletes, so it discourages the younger people from getting into that, because there can be long-term damage. It's not only the reduction in your own production, because there's a lot of guys at that young age that can easily say, "Well, I don't care, man. I'll just use for the rest of my life." And okay, I get that. Maybe you don't ever have kids, but you lose your fertility. That's a problem if you plan on having kids.
Yeah.
And if you don't mind, giving yourself injections for the rest of your life, okay, I get it. And I'm a registered libertarian. I get the whole idea. But maybe you're thinking differently at age 16 or 18 than you might think at age 30,
yep.
And you might be sorry later. Aside from that, though, when you use up until the age of, let's say, 26, we don't have a definite date where things appear to be hardwired. You're essentially crashing the boards, if you will, and you may never get the HPA axis normal again, the pituitary axis, which is the master control over the hormones. You're still developing them. You're still putting the wires together, if you will, for the long-term haul. And if you screw up the works in the middle of all that, you may have more problems than you bargained for. So, if you're going to, quote-unquote, abuse testosterone and steroids before you're actually deficient in testosterone, then, boy, you're really rolling the dice if you do it before age 26. And, I'm sure there are plenty of people out there who have used it beforehand. And, hey, look, I've fathered 5 kids, 3 more than I wanted, and all that kind of stuff, and they're doing fine. But, there are exceptions to a lot of different rules. For the most part, you are rolling the dice, and I don't know, you said don't scare them or whatever, but
that's
I
just
don't
the
mean
truth.
it is what it is.
It is what it is. Well, it's a great answer. Thank you, Doc.